Thank you for inviting me to speak today. My only disclosure is I have lung cancer. Last year, I had the honor of talking about how far research and advocacy have come over the past 19 years that I've been involved in advocacy. I talked about my devastating family history of lung cancer, losing my dad and two grandparents to it when I was 13, and then my mom and my Aunt Dee Dee when I was in my 20s. I mentioned that there wasn't a lung cancer community 20 years ago, that the only distinction doctors could make was whether or not someone had small cell or non-small cell lung cancer, and that there were only 3 treatment options for every single patient. I described the growth of our community thanks to advancements in research and treatments, and I shared my excitement about the future of lung cancer. What I didn't talk about and what's often missing in research is the critical and real world part of the story, the patient's perspective regarding treatment and personal goals. That's what I'm going to share today in the context of adjuvant therapy. It wasn't that long ago that a physician who didn't know I had lung cancer told me that he would rather be diagnosed with an advanced stage of just about any other cancer than even a stage 1 lung cancer. I bit my tongue, but looking at this slide of survival in the early stage of the major cancers, how could anyone argue? Imagine if those were your odds. Well, I can do more than imagine and tell you firsthand the devastation of thinking you are cured only to learn you aren't. There aren't words to describe how it felt at 39 years old with 4 small kids to be diagnosed with lung cancer, the same disease that killed my mom and my dad. Thankfully, unlike my parents, it was caught early and I had surgery to remove a stage 1A EGFR positive lung cancer. I was considered cured, but I couldn't stop thinking about my Aunt Dee Dee, who developed a second lung cancer just 2 years after her first. I was scared, but there weren't any proven therapies to lower my risk of recurrence or developing another cancer. There was some excitement around using erlotinib as adjuvant therapy in early stage EGFR positive lung cancer after a complete resection, and I didn't want my kids to ever go through what I went through. So I took erlotinib off label as adjuvant therapy, and it worked until I stopped taking it. 8 months after I stopped taking it, there was a new nodule on my scan, and 4 months later, I had surgery to remove what they thought was another stage 1A EGFR positive lung cancer. The surgery was successful, but I again thought about my Aunt Dee Dee, whose third cancer killed her because she didn't have enough lung capacity to survive another surgery. And unfortunately, there was new tumor growth on my post-op scan and even more on my next scan. I was lucky the cancer was contained to my chest, but after looking closer at the pathology of the resections, we learned it was the same disease, not new primaries. Erlotinib was still the only TKI approved for EGFR lung cancer in early 2013. SBRT for intrapulmonary metastases wasn't a thing, but the risks were low, so my care team and I decided it was a better option for me. And I was fortunate to use SBRT as needed for 5 years. But that ended about a year and a half ago when I had progression. And while going back on a TKI was literally and figuratively a hard pill to swallow, it was the first time I was not overcome with fear. There was hope. How is it that I had more hope and confidence with a systemic targeted therapy that won't cure me and will stop working at some point than I did when I was diagnosed with stage 1 and considered cured after surgery? That is messed up. Despite all the growth and advancements in treatment for lung cancer over the past decade, very few have been in the early stage space, particularly in lowering the high risk of reoccurrence for patients with early stage lung cancer. Early stage patients need hope. Hope matters. The true value of research for patients and their families is hope. So I understand the excitement around the ADAURA data. It is the hope that patients with lung cancer and their families desperately need. And the cartwheel in between those curves, that is the hope that doctors can finally give their patients. And when you compare it to initial DFS data of other targeted immuno or hormonal therapies and other cancers that are now standard of care to increase survival in early stage disease, you see that the ADAURA data is much better than anything we've seen in cancer. Historically speaking, it is a reason to celebrate, but the statistical narrative is only part of the story. What we patients value can't be quantified in a curve. Hazard ratios and clinical trial numbers don't translate to real life or capture the unquantifiable meaning of a person's life. Like lung cancer itself, what constitutes a meaningful benefit to each person is also heterogeneous. This data from Project Transform shows how different preferences are based on determinants such as age, stage, and gender. But preferences differ even more on an individual level. Even though I was a stage 1A patient considered to be cured, my oncologist, Dr. Bonomi, knew I wanted to do adjuvant therapy. So when I went for my consult with him, he said right away, if it were me or someone in my family, I wouldn't recommend erlotinib as adjuvant therapy. But he asked me, what are your goals? That's easy. I need to do everything in my power to live to raise my children. Without hesitation, Dr. B said, I recommend you take erlotinib as adjuvant therapy. I asked him how he could change his mind like that. He said, I didn't change my mind. For you, the benefits are unknown, but the risks are low, and your emotional well-being is just as important to me as your physical well-being. He treated me, not just the lung cancer. He understood that factors other than outcome data had to be considered when discussing treatment. And when thinking about osimertinib as adjuvant therapy, factors other than hazard ratio have to be considered, such as duration, long-term effects, access, affordability, coverage. And now there's the NEO-ADAURA trial. Will it provide the complete information needed if we can get results faster and be able to assess molecular responses? There is so much we don't know yet, but we do know that chemotherapy has proven overall survival benefit, so it shouldn't be replaced. And for adjuvant therapy in general, there are also many factors to think about, like staging, time of biomarker testing, duration of treatments. As you know, the cancer came back after I stopped taking erlotinib as adjuvant therapy. So was it worth the excruciating mouth sores, the painful rash, paronychia, etc.? It would be easy for me to say no now, but Dr. Bonomi was right about my emotional well-being. If I hadn't done everything in my power and taken erlotinib, I don't think I could look my kids in the eyes and not feel overwhelming guilt at what could have been. And my story is an example that even stage 1A patients have recurrence and up to a 20% risk of dying in 5 years. I know it's impossible to assess ongoing benefits without a tumor to evaluate, but if a breast cancer patient had that degree of risk, they would absolutely be offered adjuvant therapy. So until we have better stratification, it should be at least considered for every patient. Still, do we treat or do we not treat with adjuvant therapy? Here's the thing. Patients are asked to make a rational decision based on complex information at an emotional time when distress and anxiety cloud our ability to comprehend clearly. And as physicians, you are asked to make a recommendation with incomplete information. So what do? The important part is that you apply the medical data that you have at that time in the context of each of your patients. Personalized medicine requires getting personal. The most important part of your conversations with people and their families are not the clear data-driven ones. Talk about goals of care before you talk about treatment. Find out what's important and meaningful in their life besides living longer. What trade-offs are they willing to make? And treat the whole patient on an intellectual, physical, and emotional level. We need to know that the doctor caring for us also cares about us. We must have realistic expectations, but please remember that hope is a vital emotion for us. Erlotinib didn't result in a cure for me, and the side effects were brutal. But I have lived longer than my Aunt Dee Dee did. Is that because erlotinib altered the course of the disease and prevented it from being more aggressive? I don't know. But what if it delayed recurrence and is what bought me time I had off systemic treatment? And what if it's the reason that I have lived to see so many moments and milestones with my family? That is meaningful. That was my hope that I needed when I was diagnosed. I know many of you have heard me say this before, but I'll say it again because it's true. You may not save every life, but if you help your patients find their hope, you will make a difference in every patient's life. Thank you.